Hello, these are the podcasts of pain. Now this is part 3, where we're going to look at the basic neurophysiology of pain. Murphy in 2012 emphasised the fact that pain nerves do not exist. What do exist are a selection of peripheral sensory nerves which transmit information from the body's tissues to the spinal cord and brain via the central nervous system. Peripheral sensory nerves are categorised in terms of their size or diameter, conduction or transmission, velocity, and myelination, that's the amount of insulation and white matter constituents, as well as their specific functional role in detection or reception and transmission or afferent messaging. Sensory nerves are involved in mechanoreception, as in pressure, touch, vibration, and proprioception, as in stretch, tension and movement, thermoreception, as in heat and cold, chemoreception, the detection of chemical stimuli such as gases, hormones and chemicals released during an inflammatory cascade, baroreception, as in the blood pressure detected on arterial walls, olfactory reception, as in the sense of smell, visual or photoreception, or vision, audition, hearing, gustatory reception, or taste, and nociception, the sense of experiencing pain. The process which leads to the sensation and experience of pain is multifaceted. Indeed, nociception is the process which incorporates the detection, transmission and processing of noxious or harmful stimuli. Archer and Nelson, 2012, described this as the signal, message and perception of pain. In contrast to noxious stimuli, innocuous stimuli is that which is apparently non-harmful or injurious. A series of sensors are embedded into sensory receptor membranes. Different sensors respond, or open, to specific stimuli. Simply, these include mechanical, chemical and temperature changes. If the stimulation is noxious, or harmful and sufficient to present danger to the tissue, then as the sensor or sensors open, charged ions flow through the nerve cell. The stimulus is converted into electrical signals or impulses or action potentials, a process known as transduction, which instigates the propagation of sensory messaging of damage or irritation, as in nociception. As Murphy simplifies 2012, with regard to straightforward messaging, the main types of sensory nerve fibre to be aware of are the large A-beta low threshold fast conducting, A-delta higher threshold fairly fast conducting, and the thin unmyelinated C fibres, which are higher threshold and slow conducting. Much of the body's innocuous stimuli is detected and then transmitted via the fast A-beta fibres, and generally most of the initial noxious stimuli is detected and then transmitted via the A-delta and C fibres. The nociceptive messages arrive via the peripheral spinal nerve at the dorsal horn of the spinal cord. Messages are then transmitted via the second-order neural pathways of the ascending tracts of the spinal cord, up through the brainstem and on into the brain. Wright, in 1999, presented a detailed overview of the main neurophysiological processes involved in the upregulation of the nociceptive system in response to tissue injury. The neurophysiology of pain and associated neuroplasticity may be summarized as being the immediate, short and longer-term neuronal and chemical responses and adaptations which occur. Practitioners dealing with injuries and pain must be advised to develop their appreciation of peripheral sensitization, central sensitization, motor dysfunction, autonomic sympathetic dysfunction, and the resulting psychosocial effect and subjective pain experience. As Wright from 1999 explained, the nociceptive system is normally quiescent and requires relatively strong and potentially damaging stimulation before it becomes activated. Once pain is manifest, it should be recognized that relatively innocuous or normally non-harming stimuli can reactivate the system. When an individual's pain experience becomes exaggerated or heightened, the experience is termed hyperalgesia. Sensitization can be considered as the increased sensitivity to subsequent stimulation. Hence, peripheral sensitization is the process of upregulation and increased responsiveness and reduced threshold of nociceptive neurons in the periphery to the stimulation of their receptive fields. Peripheral nociceptors are polymodal, which means that they respond to chemical, thermal and mechanical stimulation. Essentially, and in the case of localized soft tissue injury, the release of prostaglandins, histamine and bradykinins chemically excites sensory receptors. This is enhanced by substance P and calcitonin gene-related peptide or CGRP, which are released from the nociceptors into the tissues which induce mast cell degranulation, which then stimulates further release of histamine and serotonin. And all this is part of the normal local inflammatory cascade. Central sensitization, or long-term potentiation, is the process for neuroplasticity occurring in the spinal cord and brain in response to upregulation of the peripheral nociceptive system. Song and Carr in 1999 explained how central sensitization occurs within the dorsal horn of the spinal cord, the brainstem and the brain, and that the resulting amplification of nociceptive inputs to the spinal cord can cause a secondary hyperalgesia at the site of injury. One component of this occurs when nociceptive messages begin to arrive at the dorsal horn and the neurotransmitter glutamate is released at the synapse. Glutamate normally binds with the AMPA receptor, AMPA, alpha amino 3-hydroxy 5-methyl 4-isoxyl propionate. It's hard for me to say. To facilitate propagation up into the ascending tracts. In the presence of any prolonged nociceptive messaging, glutamate may bind with a previously unavailable receptor, the NMDA, N-methyl-D-arginine receptor, which enhances the flow of electrically charged ions across the postsynaptic membrane, which then facilitates improved sensory messaging. This particular process is self-perpetuating in that the second-order neurons also release chemicals which stimulate increased release of glutamate. Such adaptation develops or amplifies the individual's pain experience, and they may sense a spreading of pain away from its primary location, as in tenderness and aching, increased guarding, as in muscle spasm, and possible skin temperature changes. Mechanical hypersensitivity and allodynia to innocuous stimuli results via the A-beta low threshold excitation. The muscle spasm commonly associated with central sensitization may be explained as motor dysfunction and involves heightened excitability in alpha and gamma motor neurons. Such muscle spasm can lead to increases in local metabolite production and circulatory impairment, as well as increase in the pain. This is due to perpetuating the mechanically stimulated nociception, and the well-documented ongoing vicious pain spasm cycle develops. Both peripheral and central sensitization can lead to autonomic sympathetic dysfunctions. In normal conditions, there is little communication between sympathetic postganglionic neurons and afferent neurons, but the presence of pain associated with tissue damage and the adaptive sensitizations can lead to alterations in sympathetic function. The centrally sensitized, sympathetically maintained state of pain may result from excitation of mechanoreceptors by sympathetic efferents. The type of pain which results depends up to a certain degree both on the type of sensory nerve fibres carrying the information and the type of tissue involved. Sharp, painful stimuli may be carried by the relatively larger and faster A fibres, which conduct nerve impulses at speeds of between 6 and 30 microseconds. Dull, achy pain is more likely to be carried by the thinner and slower C fibres, which can conduct at speeds of 0.5 to 2 microseconds. High pressure mechanoreceptors respond to large changes in pressure, such as those resulting from a blow to the skin or where a shearing force is applied to the tissues. Free nerve endings can respond to changes in heat or acidity and are chemotaxic. There are also nerve fibres that are receptive to ATP. ATP appears to be released from damaged tissues, especially damaged muscle tissue, as it's present in high concentrations within skeletal muscle tissue. When the muscle is damaged, ATP is released into the tissues, which then activates the receptors. Signals of pain are relayed from the involved receptors via the somatosensory pathways between the receptors and the central nervous system. Axons from the pain receptors enter the CNS via the peripheral spinal nerves. When the dorsal root ganglion of the cord, the afferent neurons synapse with the ascending neurons and release neurotransmitters such as substance P and glutamate. The postsynaptic neuron exits the spinal cord via the spinothalamic tract on the opposite side of the brain and relays via the medulla oblongata through the lateral lemniscus of the midbrain to the ventral part of the thalamus. From here, the signal is directed to the primary somatosensory cortex, the insula, and the cingulate cortex of the cerebrum. The somatosensory cortex contains cells that map different parts of the body, and cells have been located here that respond to pain signals coming in from different parts of the body. As the brain receives these nociceptive messages, it's then challenged to interpret them and respond appropriately. The recognition of pain in itself is a complex process. The incoming nociceptive messaging of newly occurring pain is automatically placed into context with the individual's additional immediate visual, auditory and other messaging, and with the type of pain which is being experienced. At the same time, the cerebral cortex flashes a multitude of additional messaging regarding past experiences of injury and pain and the emotions of such. In a sudden episode of acute pain, the individual is likely to be primed to produce immediate reflexive responses, i.e. the monosynaptic spinal reflexes cause the individual to move quickly away from the cause of pain. As this occurs, multisynaption also occurs via the ongoing ascending transmission of responses to the nociceptive inputs, and the autonomic sympathetic nervous system will also become excited. Processing is different with chronic pain, where sensitization is apparent, and especially where psychosocial factors may have influence on pain perception. Waddell, in 2004, Main and Spanswick, 1999, amongst others, each discussed the impact of psychosocial factors, intrinsic and extrinsic, on the experience of pain and the potential for recovery. Such factors include negative feelings and behaviours, catastrophizing, and preconceived ideas, as well as the external stressors relating to work, sport and personal situation. In the 1960s, Melzack and Wall, in 1965, proposed a theory to try to explain why pain perception can differ between person to person and from time to time. This has become known as the gate control or pain gate theory. Melzack and Wall identified that areas of the spinal cord receive inputs from both peripheral pain receptors and other peripheral sensory receptors, in addition to axons descending from the brain. If the other peripheral sensory inputs are highly activated, they can close the gates for the pain messaging, so that the brain may filter out pain information to some degree. The gating is affected by the degree of different activity in the large and fast A beta fibres and the small and slow C fibre nerves. The theory suggests that the stronger impulses travelling along A beta fibres tend to block the slower pain transmissions, closing their gates at the dorsal horn. In a sense, such messages will be presynaptically inhibited. It's implied that increased activity in the A delta and C fibres tends to facilitate transmission or open the gates. It's a popular theory and it's still presented today. Indeed, it's a commonly used explanation for the use of a range of therapeutic intervention, from TENS and acupuncture to soft tissue therapy, ice and heat. It's recognised that non-painful stimuli can both increase and decrease pain signaling. The central nervous system is being shown to produce and release a range of molecules known as the endogenous opioids, which are similar in structure and function to the opioid molecules of the opium poppy and have analgesic properties. Receptors have been found for the opiates in the same brain areas that substance P is concentrated. As such, activation of the opiate receptors seems to limit the pain-producing effects of substance P. A selection of these molecules are produced, including met-enkephalin, leu-enkephalin, and dynorphin, and collectively these are termed endorphins. The region that releases endorphins is called the periaqueductal grey of the brainstem. When endorphins are released from here, they excite cells in the medulla, the medulla oblongata. Neurons from the medulla and the periaqueductal grey then send signals to the appropriate parts of the brainstem and spinal cord, which blocks some of the release of substance P and therefore can decrease pain. A-delta fibres do not use substance P as a neurotransmitter. Instead they use glutamate and are not affected by the release of endogenous opioids, whereas the slower C fibres do use substance P and hence are susceptible to the action of the endogenous endorphins. This may explain why opiates, such as morphine, are not effective in relieving sharp pains, but are effective in relieving deep, dull, prolonged pain. The sports therapist is challenged in their practice to be able to both assess and understand the pain presentations of their patients, incorporating the previous medical history and identifying the possibility of any red flags or psychosocial factors or yellow flags. To empathise rather than sympathise, and importantly to provide appropriate treatment and manage, which in complex or concerning situations may essentially involve medical referral or clearance. In the case of relatively uncomplicated sports injuries, sports therapists will design their interventions so as to support the healing process of involved tissues. This will include first aid techniques in the immediate stage, judicious use of clinical therapy in the earlier and later stages, including methods such as cryotherapy, interferential therapy, ultrasound, soft tissue therapy, manual therapy, taping, strapping, and heat therapy, and progressive exercise rehabilitation. Okay, I'm sure that was quite confusing, complicated, long-winded and challenging to grasp, but we're all in that same boat. It's a complex field and we need to have some basic appreciation of it at least. Hopefully that covers some of the ground that will be useful for you to appreciate pain. Okay, thanks very much. See you soon.
The podcasts of pain. The podcasts of pain. 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 Pain.